So today we are going to deal with the case history, importance of case history, and why you want to take the case histories and steps in taking case histories. So importance of case history. It is first and most important step. We have to record the case history, and for the proper diagnosis and to properly plan the treatment, we need a correct case history. So first one, we have to deal with the name. So why you want to know the name? We have to create a bond with the patient, and for proper communication and for keeping the record purpose, we have to know the patient's name and we have to record it. When it comes to the matter of age, it is mainly some diseases are most common in certain age groups. Like aggressive periodontitis is more common in young age, while chronic periodontitis is most common in old age. And other wasting diseases like attrition and abrasion, they are commonly in elderly patients. And the gender also we have to know and we have to record because some localized aggressive periodontitis having a more predominance in females, and osteoporosis is most common in postmenopausal women because of the hormonal changes. And the social status we have to know, that is mainly for the to know the patient's attitude towards the dentistry, and if it is not socially very high status, some people are having an encourage towards this poor oral hygiene and fewer visits to dentists. So we have to know the social status of the patients and how they are dealing with it. And occupational, we have to know very importantly because occupational stress is a main common factor nowadays. So we have to know the occupational stress, whether the patient having any bruxism or something for that, attrition, wasting disease, and whether problems, stress is very important. And people working in chemical factories, there's a chance of getting erosion and adrenal sensitivity. So we have to know the occupational status of the patient. And for the communication, we have to know the address because, and not only for the communication, we have to know whether the patient is coming from any endemic area. So certain diseases are maybe more prevalent in certain areas. So the geographical distribution of the diseases like dental fluorosis and all. So we have to know the address of the patient. And next, the main thing, chief complaint. We have to record the chief complaint in patient's own words. And it should be in chronological order, and there should not be any medical term should be included in the chief complaint. While recording the history of presenting illness, we have to know when it starts and what type of pain. If it is a pain, they are mentioning about any pain or something, we have to locate the pain and the radiating status of the pain, whether it is radiating to some other areas like the head, neck, or shoulders, or it is a localized pain. All these things we have to know, and the duration also we have to know, and the character like sharp pain, dull pain, all these things we have to record in the history. And ask the patient whether there is any relieving factors, whether they have taken a medication or something to relieve the pain, or any like that. The same thing we have to know whether the patients have any increasing aggravating factors. Like some people tell that they have any more while masturbation or chewing, they have more pain or something like that. So we have to know the aggravating and related factors and the severe pain. Sometimes having a diagram variations, there is some type of pain there will be more in night time, and some type of pain there will be more in the daytime. So all these things we have to know and consider while taking the history of present illness. And past dental history is very much important to know the attitude towards the post dental treatments and the previous treatment strategies and any complications that happened in the previous during the previous treatment and all. So we have to know all these things, and more, in addition to that, in perio aspect, if there is a missing tooth, we have to know the reason for the missing tooth, whether it is due to caries or whether it is due to mobility. If it is due to mobility, then that is our main concern, because then definitely we will get an idea that the person has a periodontal problem. From that moment itself, we can identify. So the reason for the extraction of the tooth, that also should be considered during that time. And coming to the medical history, we have to know the medical history of the patients, because many treatments we have to take some precautions while doing our medical treatments, and we have to give some pre medications also So we have to know the medical status of the patient. And if the patient having its diabetic or something, we have to know the HbA1c level for the past 3 months and BS, BS status, all these things we have to know. And whether the patient and so many things like drug interaction and all will be more common. So we have to know the status. And drug-induced gingival enlargement is most common in hypertensive patients. So we have to know the medical status of the patients and any medical allergy or drug allergy or things we have to note down in the medical history. So we should be very careful and we don't skip that medical history part. Coming to the family history, we have to know the genetic factors. So this we are just checking that any family history of systemic diseases and also the dental disease like periodontitis. If the patient's parents or immediate siblings or something, if they're having a history of periodontitis like losing of teeth in young age itself, the baby definitely the patient also having it likely to have the chance of getting the disease very fast. And the personal habit is another important factor. We have to know the chewing habits. We have to know the brushing habits of the patient. Which all oral hygiene measures they are taking, what technique they are using for their oral hygiene, they are taking better, toothpaste type, brush type, all these things we have to know. And we just, most important factors, we just want to know how frequently they are replacing their toothbrush. All these things we have to record in the personal history. And heart tissue examination, we have to know the status of the teeth present, filling, stains, and deposits, all these things. And the attrition, abrasion, and all the other wasting diseases. And we have to know attrition means the loss of tooth structure that is mainly due to the tooth-to-tooth contact during the masticatory or parafunctional habits. So parafunctional habits are mainly bruxism, cleansing, all these things. So we have to evaluate all these things during this time. And abrasion is mainly due to the biomechanical frictional force that is mainly caused because of the toothbrushing, excessive toothbrushing or faulty toothbrushing technique. And erosion that is mainly used because of the GR, that is gastroesophageal reflux disorders. So that is mainly due to the dissolution of the acids or intrinsic, that is extrinsic ozoin. Intrinsic ozoin, that is gastric acid, that's the GRD that I have already mentioned right now. And dietary acids, like if the patient is consuming more hydrated drinks and all, there will be chances of getting the erosion is most common in the like that patients. And abstraction, that is mainly due to the biomechanical loading of frictional force due to the tooth flexure. And that is mainly there will be cracks or striations of also shaped changes we can see over there. That is mainly the abstraction. And occlusion type we have to know. In our foot impaction also we have to check. There are two types of foot impaction: vertical foot impaction and horizontal foot impaction. Vertical foot impaction is mainly due to the open contacts, and horizontal foot impaction that is mainly due to the enlarged gingival embryones that forces the foot to wedge into the periodontium. So, and the plungicus is the cusp that is forcefully wedges the foot into the periodontium. That is sent to forcefully places the foot inside the periodontium. That we have to, that also we have to check whether the patient having a plungicus. Then proximal contacts, open contact area is the malaligne tooth. All these things we have to note in that area. And pathological tooth migration, but the tooth displacement that occurs when the balance among the opposite forces that maintain the tooth position is disturbed by the periodontitis. That is the pathological tooth migration. There will be flaring, extrusion, drifting of the affected tooth. We can see most common there will be diastema and facial flaring will occur in posterior pathological tooth migration. Then comes the fremitus stress. That fremitus stress we have to check mainly for the trauma from occlusion. Trauma from occlusion is the when the occlusal force exceeds the adaptive capacity of the tissue injury occurs. That occlusion is called traumatic occlusion, and that process is called trauma from occlusion. So we have to check whether the patient is having any traumatic occlusion or trauma from occlusion. For that, we have to do the fremitus stress. A dampened index finger we have to place on the buccal and radial surface of the maxillary teeth and ask the patient to bite in the maximum indivisible position. And we have to check the changes. So there are three classes. Class 1 is mild vibrations or movements we are detecting while backbreaking. Class 2 is easily palpable vibrations we can move. And class 3 is the movement that is visible with the naked eye. So in this way, we have to check the fremitus test and we have to record the trauma from occlusion. And if there is trauma from occlusion, we have to record the grade of the trauma. And soft tissue examinations, for the examination part of gingiva, we have to check carefully the color of gingiva. So the main factors that determine the color of gingiva are vascular supply, keratinization, thickness of the epithelium, and pigmentation. So pigmentation, the normal color of gingiva in Asian population is pink with pigmentation. If the pigmentation is present only, then there is no need to write the pigmentation. What you see in the oral cavity, that you have to write it over there. Normally it is coral or pale pink. In chronic periodontitis and all, it will become more pinkish in color or bluish in color. And in acute periodontitis, there will be more bright in color in this. And contour is normally healthy and scalloped with a knife edge. But in cases of inflammation and all, there will be exaggerated scallop with the round or blunt edge also we can see. And consistency is normally it is firm and resistant, but in some cases like inflammation and all, it will be becomes more spongy or edematous in appearance, and because that is mainly because of the fibrotic changes. And margin gingiva is mostly easily displaced from the tooth surface with a light blood that indicates the destruction of the teeth, destruction of the gingival fibers that supports the gingival margin. And coming to the surface texture, it is most commonly the surface texture of the gingiva, it is stippled in appearance. There is the orange peel appearance. But in some cases, like inflammation and all, either this stippling will be reduced or either the stippling will be completely absent. So we have to note whether the stippling is present or not. The stippling will be start presenting in oral cavity from the age of 5 years only, and it increases in until adulthood age and start disappear in old age patients. And the size, we have to check the size of the gingiva, whether it is normal in size. In case of inflammation and all, there will be a chance of getting more enlarged in that condition. So we have to check all these things in of the by taking the case history. And the position is very important part. So normally the position of gingiva is at the level of CG. But in case of recession, there will be it is more apical, and in case of enlargement, it will be more coronally placed. And next is the gingival exudate that we have to check by applying lateral pressure over the from the apical portion towards the coronary area. And the gingival exudate is an inflammatory exudate that is most commonly because of the inflammation. We have to apply the slight pressure on the lateral surface of the gingiva, and we can say white purulent material that is oozy nerve. That is the gingival exudate, and we have to record whether it is present or not in association to that particular type. Next, we have to check the bleeding on probing, and the method is known as running the probe. We have to run the probe towards the through the gingival surface and wait for 30 seconds and check for the bleeding. That is also grade 1, grade 2, grade 3. Grade 1 means mild pinpoint bleeding. Grade 2 is pinpoint bleeding that forms a line. And grade 3 is with the there will be profuse bleeding. So all these things we have to record, and we have to check whether the any of the area having this bleeding on top. And that is the first sign of gingivitis, that's the bleeding on probing. And in smokers, there will be reduced bleeding on probing due to the nicotine effect. Then we have to check the abrasions that we will give in the next case.